Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a deep look at the latest innovations related to musculoskeletal medicine. Now, when a new treatment comes out for pain, I'm typically cautiously optimistic. I've had enough trips around the sun to see a lot of treatments come and go. So I like to see real-world evidence, not just industry ads, and I like to see consensus guidelines from clinicians that have a proven track record with a particular treatment. Well, we just got it for a 60-day peripheral nerve stimulation therapy, making it a really revolutionary way to treat several painful conditions. In June, the Journal of Pain Research published guidelines from the American Society of Pain and Neuroscience for the use of the 60-day peripheral nerve stimulation therapy. Now, the idea of stimulating a nerve to reduce pain is not a new one. The concept of gate control theory of pain perception was introduced, and peripheral nerve stimulation was tried in the 1960s, before my time. Now, it's important that we make a distinction between spinal cord stimulation or dorsal column stimulation and also dorsal root ganglion stimulation. Those highly effective treatments involve stimulating at or just outside of the spinal cord. Peripheral nerve stimulation is stimulation of nerves that are further away from the spinal canal or the spinal cord. When people say neuromodulation, it can include any of these treatments, but today we are talking specifically about a 60-day peripheral nerve stimulation therapy. The exact way it works isn't known. However, we do know that chronic inflammation of peripheral nerves leads to hyperexcitability, which results in a phenomenon known as peripheral sensitization. These peripheral nerves repeatedly fire abnormal signals to the spinal cord. That overstimulation of nerves, called wide dynamic range neurons, leads to changes in the spinal cord and the brain called central sensitization. In the spinal cord, a specific cell, called the glial cells, causes increased excitability of pain pathways. Also, pathways that normally suppress pain by neurotransmitters like GABA are decreased, which then subsequently increases pain signaling. A similar process in the brain results in changes in a part of the brain called the somatosensory cortex. By stimulation of the peripheral nerve that is sending that signal to the brain and spinal cord, it is theorized that we can reverse the maladaptive oversensitization. In the past, with peripheral nerve stimulation, a person would have a trial of a temporary lead, and if it worked, a permanent lead would then be implanted. The length of the trial was often no more than 10 days because of risk of infection. The problem here is that studies have found that about 30% of patients who got relief actually did so after 15 days. The authors called them delayed responders. So in that shorter trial of 10 days, these people would have been mislabeled as not getting relief. A smaller number of patients got relief early, but it wasn't sustained. So a newer design for these 60 days is great because it lets us identify patients who maybe need a little more time to see if it's going to work or not. This allows time to capture those patients who might be more delayed responders and also gives time to overcome the maladaptive oversensitization that has occurred due to the chronic pain. After 60 days, the system is then removed without the implantation of a permanent system. Now, there are several studied applications of peripheral nerve stimulation. There is good evidence for use in low back pain, postoperative foot and ankle pain, postoperative knee pain, neuropathic pain, post-amputation pain, and shoulder pain. There's also evidence of benefit in neck pain, although it's less well studied than the lumbar spine. As an emergent therapy, there will be more evidence hopefully to come to even further hone down for us which patients get the most relief. I'm probably most excited about this therapy for low back pain. In low back pain, the electrical stimulation is applied to the medial branch nerve. This nerve innervates the facet joints, which are commonly painful and arthritic, as well as a deep back stabilizer muscle called the multifidus. Studies for this show really promising results. One study showed that 91% of back pain patients had clinically meaningful improvements during the 60-day treatment. And this improvement persisted in 91% of subjects after 2 months and in 77% at 14 months. After 12 months, 60% of patients were still reporting clinically meaningful pain reduction. This therapy is clearly providing a longer-term pain relief than many of the standard treatments we're using now. The consensus guidelines showed moderate to strong evidence for benefit for back pain even after someone has had other procedures, like radiofrequency ablation. So radiofrequency ablation is a very common technique that we use where a needle is used to heat the tissue of the medial branch nerve, and it causes injury to it. That prevents that nerve from sending the pain signal. These nerves, however, can grow back, usually do grow back, and pain can recur. Particularly interesting is in that patients who'd had PNS after radiofrequency ablation, there was very significant improvement in functional outcomes, including 87% showing reduced disability and 80% experiencing reduced pain interference. So this treatment helps a lot of people, and the benefit is long-lasting for a lot of patients. Peripheral nerve stimulation is a potential therapy even in patients who've tried and failed other treatments, which is a great hope for low back sufferers. We do want patients to wait 6 months after radiofrequency ablation of that spinal region before we try PNS, though. Now, we talked earlier about centralized pain and how some injury causes some hyperexcitability in the nervous system. This is a mechanism of interest, particularly into why some patients don't respond to interventions or even surgeries. So why does someone have a surgery, doctor fix the anatomical problem, yet they still have pain? Well, in this instance, the centralized pain process can be the culprit. So could we use this therapy before surgery to minimize that centralization, or could it provide further relief after a surgery? Now, okay, admittedly, that's an area we don't have an answer to yet. Now, the lead is placed through a small needle. The doctor uses a live X-ray called fluoroscopy, or in some cases ultrasound, to identify the correct location. The doctor will then stimulate to ensure the correct location before securing it to the skin. The stimulation feels like a mild pulsing or tingling at the painful site. The stimulation is not turned up high to be uncomfortable and does not need to be left on continually. The system shouldn't feel like a TENS unit on high for those of you who have tried it, but mild and comfortable. For a week or so after the placement, the patient will avoid strenuous exercise, and while it's in place, they need to avoid tugging on the skin of that area. A dressing needs to be changed, and while the person can shower, they shouldn't go swimming or submerge the area. We live at the beach, and a lot of my patients are boaters, so as you can imagine, in the Southeast, this is probably more commonly done during the cooler months. After the first week or so, we want the patient to start doing some exercise, physical therapy, and try to restore normal function to that area. Restoring more normal movement and function further decreases the central sensitization. We want the person up and about. It's not just about pain relief, it's about improving function and quality of life. Now, the shape of the lead and its very small size allow it to be left in place with a dressing covering it for the 60-day therapy. It's not a trial, guys. It's a 60-day treatment, which for most people has long-lasting benefit. Infection rates are very low, less than 1%, due to the lead shape and the dressing. Because it's placed outside of the spinal canal, we have less concerns about bleeding as well, and this is good for patients who need to take a blood thinner and aren't allowed to stop it because of cardiovascular risk. The most common adverse reaction is skin irritation at the dressing site. The lead can also break, however, the rates of that are typically low, and it's usually just left in place since it's extremely small and wouldn't be causing any problems anyway. Now, this differs from spinal cord stimulation and dorsal root ganglion stimulation, and while some of the pain that they treat overlaps, it does not replace these therapies. Some conditions, like post-laminectomy pain syndrome, where someone's had back surgery and still has pain, are in most instances going to be better treated with a spinal cord stimulator versus a peripheral nerve stimulator. Deciding which treatment to pursue depends on the patient's pain pattern, their health, and their surgical history. But this is a really exciting tool in the toolbox of neuromodulation therapies. One exciting application is to use this to reduce pain, allow a person to return to more normal activities, and then see if the pain relief is long-lasting. If it is, great. If it isn't, then we move to a more permanent system. Thank you so much for listening today. Please like it, subscribe it, share it with your friends if you learned something. Thank you again. Wishing you good health and see you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.